All right. Want to welcome everyone to another NIHD Healthy Lifestyles talk. Tonight, we're going to be talking about understanding diabetes, a three-pronged approach to healthy living with type 2 diabetes. We have three different speakers for you tonight to approach diabetes in kind of three different directions, which we're super excited about. So to get things started, we're going to start with Elizabeth Haun. She is one of NIHD's advanced practice providers working alongside the rural health clinic team. Elizabeth's goal as a family nurse practitioner is to provide equitable healthcare services to our community and work towards establishing a comprehensive, self-educated diabetes education program. Elizabeth earned her registered nursing degree from Hartnell College in Salinas and her FNP certification from West Coast University. Elizabeth, thanks for joining us tonight and look forward to your talk.
Thank you, Dr. Hawkins. Okay. Okay, so the first thing that I wanted to bring up, and this is a lot of information, but briefly, the American Diabetes Association releases periodically new standards of care in diabetes prevention, diagnosis, and treatment. And so the things that I wanted to point out on this slide are basically some interesting new releases in the standards of care that have come up. And one of them is, they're increasing the amount of weight loss that is recommended. They're also bringing up a recommendation for sleep health, which they haven't done before. And we're just really starting to learn about how important sleep is in all sorts of health conditions. And they're also bringing up the social determinants of health, or rather, that means that there's really putting an emphasis on food security and what you're able to get in your house to eat, and your socioeconomic status, what you can afford, and looking at basically more of like the whole picture of the person, as opposed to just if rather they're taking their medications and doing what the doctor's telling them. Go ahead, Barbara, next. So one thing that I like to think of myself as a diabetes advocate. So people with diabetes should not face discrimination. We should be advocating for people and the rights of people living with diabetes, and it should not be difficult for them to be able to get their supplies and live like everybody else lives. Diabetes care should meet all standards in school settings for young children in healthcare, for occupational drivers, work settings, and in correctional institutions. Go ahead, Barbara. Next. Okay, so these are some statistics about diabetes. It is a global epidemic, and so 537 million adults around the globe are living with diabetes. So that's 1 in 10. And almost half people living with diabetes are undiagnosed, so they don't even know they have it. 3 in 4 adults with diabetes live in low and middle income countries. That's a lot. That's like 3/4 of the people with diabetes live in poverty. Go ahead, Barbara, next. So this is the diabetes statistics from the United States. So we have 38 million people living with diabetes. That's about 1 in every 10 people. And again, in the US, 1 in 5 people don't know that they have it. And there's about 1 in 3 people who have pre-diabetes, and 8 out of 10 people with pre-diabetes don't even know that they have it. They haven't even been diagnosed. And the medical costs to our medical system are astronomical, 413 billion in medical costs. And So if somebody has diabetes, it doesn't necessarily mean that they have diabetes. They take medication and then they're better. We also have to look at problems associated with diabetes, which are blindness, kidney failure, heart disease, stroke, and loss of legs, toes, feet, and other problems that are associated with diabetes that we have to really be concerned about. So it's not just diabetes, it's all these other conditions that come along with it, potentially. Okay, next. So this is just a simple graph to show in the last 20 years the increase in diabetes. And so starting from about 2001, 2000, let's say, there's been a pretty good increase in people with diabetes total, diagnosed and undiagnosed. It's especially the diagnosed. We're getting better at diagnosis, so that's been going up substantially. Go ahead, Barbara. So going back to the diabetes standards of care, these groups of people, Native Americans, Alaska Natives, people of African American origin, people of Hispanic and Asians, they have, not the Asian population, but the others have higher than the general population of diabetes. And this is directly correlated with their socioeconomic status. So we know that these groups of these ethnic groups have lower socioeconomic status. They have less education and they have less opportunities in life. And so if you have a high school education or more, you're 7.1% likely to have diabetes, as opposed to just a high school education, which is 9.2. And if you have live with an income below the poverty level, you have the highest prevalence of diabetes, 13.7 to 14.4%, which is higher than the 10% of the general population. Go ahead, next. So like I said, we have many associated conditions related to, and actually we can go on, we can skip this one because I already went over this slide. Thank you. So there are two types of diabetes. There's type 1 diabetes, and the type 1 is an autoimmune disease, which basically means that your body destroys your own pancreas. And so since you don't have a pancreas, you don't have any insulin at all. And so you're typically insulin dependent. And this is about 10% globally of the population of total diabetics. Typical onset is in children, teens, or young adults, but it can happen later in life as well. So even though you're insulin dependent, it's still important that you have a healthy diet and exercise, because it does help to manage the diabetes, and potentially you can take less medication if you have a good diet and exercise. And type 1 diabetes has been shown to have, a person with type 1 diabetes has a 13 years less than average of life expectancy. Go ahead, Barbara. Go back one, please. Thank you. So type 2 diabetes is a chronic condition that affects the way your body metabolizes glucose, or sugar that you eat in your foods. Insulin is required to move sugar into the cell, and basically the majority of our cells in our bodies require the insulin for energy. Require sugar for energy. So type 2 diabetes is two factors. It's the inability of our cells to recognize the insulin. That's the one factor. And then the other one is that the pancreas does not produce enough insulin to manage all the sugar in our bodies. So go ahead, Barbara. And this is just a slide to show how kind of complicated this whole process is. And so on the right, we have the insulin molecule. It tucks itself into the insulin receptor. the insulin receptor triggers this pathway inside the cell, and then the cell opens these gates that are on the left, and that's able to suck the glucose in from the bloodstream through these gates. And so, like I said, there's two factors to type 2 diabetes. One of them is what we call insulin resistance. So that means that the insulin receptor that we have on the right side of the screen here on the cell wall doesn't recognize the molecule that's floating around in the bloodstream. And then the other factor is that these little yellow dots that you see on the on the left of the insulin that's waiting to drop into the cell when the gates open, there would be far fewer of these insulin molecules floating around, because your pancreas is only, once you have diabetes, you only have about 20% of your pancreas that's actually functional at this point. So go ahead, Barbara, next. So this is sort of an example of somebody who does not have diabetes on the bottom and somebody who's a type 2 diabetic on the top. When you eat, generally, if you don't have diabetes, I like to think of it that way as opposed to normal. I mean, everybody's normal, right? In some ways, or everybody's abnormal in a lot of ways. But so the person with diabetes on the bottom, in 2 hours, basically you get a nice peak after you eat, and then if you're producing the amount of insulin that you should, your blood sugar drops down to normal at about 2 hours. Whereas on the top, the green line is somebody with diabetes who eats, they get the nice sharp peak, but then as you can see, they don't really ever get back to normal. It does not drop down. And and here we're 5 hours out and we're still not back down to normal levels. So basically that means that you have too much sugar floating around in your bloodstream for too long. Next. So these are the risk factors that make you more likely to get diabetes. The first three are what we call the factors that we can control. So that's weight, fat distribution, and inactivity. So weight, so the more fatty tissue you have, the more likely that little receptor on your cells won't recognize the insulin. And also where the fat is. Abdominal fat creates more, puts more pressure on the pancreas. It's more difficult for the pancreas to produce the insulin, and so it causes more insulin resistance. Inactivity, exercise uses sugar in the body for, it's actually, how do I explain this? So muscle cells, when you eat and then you exercise, muscle cells don't necessarily need to use insulin all the time to suck those glucose molecules into the muscle. So if you eat, say, for example, and you go out and you do like a quick walk, then you don't need to use as much insulin to move that sugar back into the cells, muscle cells anyway. And then we have the factors that are out of our control, which are your genetics, your race that we already talked about, and your age. And so your genetics, you're more likely to get diabetes if you have a parent or sibling that has type 2 diabetes, or both parents. Race, we already went over that. And then age, your risk significantly increases after age 45. And one of the statistics that I think might be coming up says that over age 65, almost half of people over age 65 actually have pre-diabetes. That's a lot. Next slide, please. So these are just some of the symptoms of hyper and hypoglycemia. So on the left is when you have too much sugar in your blood, and on the right, you have too little sugar. And it's just kind of a cute little, with the emojis and stuff. I thought it was kind of clever. So anyway, let's move on. Yeah, you can skip this. We already went over this. Thank you. Okay, so this is just how diabetes is diagnosed. And We don't really use the middle one very much. That's a 2-hour plasma glucose test. And that's a test where you go into the lab and you drink a bunch of horrible tasting sweet stuff. And then within a certain amount of time, and then they test your blood sugar at 1 hour and then at 2 hours. And like I said, that graph that I showed you earlier, they're checking to see if your blood sugar is going back to normal at the 2-hour mark. If it doesn't, then, then we might diagnose you with prediabetes or diabetes. The fasting plasma glucose is when you go into the lab and you get your blood drawn, they check your blood sugar right at that moment of the blood draw. And so that gives us kind of an indication, especially you have to go in fasting. And so we know that if your pancreas is working okay and you don't have insulin resistance, then your blood sugar is going to be normal. It's going to be between 100 and 125. The A1C at the bottom is a 3-month average of your blood sugar that's been circulating in your blood that we check. And these are the values. 5.7 to 6.4% is prediabetes, and then anything above 6.5% is diabetes. So we look at that. That's about, like I said, since it's a 3-month average, we check it every 3 months to see how you're going. Go ahead. So if you're checking your blood sugar at home and your blood sugar is not very well managed, then basically you have to prick your finger about 4 times every day to get random readings per day. And then once you get better control, then you can do it once or twice or a few times throughout the month. Like I said, the A1C typically is monitored every 3 months. So the oral medications for diabetes address those 2 factors that I talked about. One of them, sorry, I'm about to be locked out. Okay, there we go. One of them produces the pancreas to produce, stimulates the pancreas to produce more insulin. So that's one of the things that medications does. Then we have other medications that will decrease the insulin resistance. So we put people on one or the other, sometimes both. There's also insulin that you can inject that helps. Like I said, type 1 diabetes, they are insulin dependent. So that's generally all they're doing is the insulin. And then it's typically dosed with your ingestion of sugars. Go ahead, Barbara, next. So this is just an example of some of the oral medications that on the left and then the insulins on the right. And like I said, this is just an example. There are probably 2 or 3 more pages of these medications. We have so many diabetes medications out nowadays. It can be overwhelming, but it can also be great because we can really kind of fine tune your medication and get you into the normal ranges. Okay, next. So I just wanted to bring up these 2 medications that have been in the news lately, Ozempic and Wegovy. They're a really kind of hot topic right now because they work in such a way that they will decrease people's appetites and people end up losing weight without really much effort. And I guess what I want to say about these drugs is that for people who really need them, they're really helpful and they do a great job, and they're still kind of somewhat new. We still have new information coming out about them all the time. Just like any medication, they have side effects that we have to be careful with. You can't just start taking the medication straight up. You have to start slowly and work up to it. It can cause digestive problems. And then the other thing is that, if you are just wanting, we can order these for the Wegovy. We can order them for weight loss for people who need them. And the thing that I just wanted to bring up about how important these drugs are is that they are very important and very effective for people who really need them. But because there's such a craze now for these drugs, we really are having a really hard time getting them. They're very, very difficult to get for our patients. Pharmacies are struggling, there's a shortage. And, if anybody has any questions about these medications, I'd be happy to answer them. Go ahead, Barbara, next. So the medical management for diabetes, changing dietary habits is very difficult. It's probably one of the most difficult things that we can do. And for somebody who has, let's say they have lactose intolerance, so when they drink milk or have a milk product, they have kind of immediate reactions to where they get diarrhea, they don't feel good. That's something easier to let go. It's like, oh, I don't want to drink the milk because it's going to make me sick. Diabetes is just like high blood pressure. I call it the silent killer because you don't feel it when it's going on, but then later you start having problems. And so it's very difficult. We don't have that instant gratification of feeling sick when we eat something high in sugar. And we all know how to eat better, despite all the overwhelming and conflicting diets. And my colleague Kalina is going to clear some of that up for us. The trick is just finding a long-term sustainable way to eat healthy. So with that, I'm going to pass this on to Kalina. She's our dietary services guru.
Awesome. Thank you so much, Elizabeth. I had a question for you. If you're a patient or you have a family member and they are worried that they might have diabetes or pre-diabetes, I'm sure most of us know a family member or a friend who's experienced diabetes, and there's all kind of anecdotal experiences that go along with someone that has diabetes. One question I have is, how does a patient start the conversation with the provider? Do they need to engage the provider to say, hey, I'd like to be tested for diabetes, or is that something that their primary doctor is going to set up for them? And then a follow-up question would be, if someone does have diabetes, do they have to be treated with insulin? Do they have to be on pills the rest of their lives? Just what is the trajectory of someone? I know that gets diagnosed with diabetes, and I know that's a nuanced answer, but I'm just hoping to kind of give people a broad understanding of what the process looks like of getting diagnosed and screened, and then the next steps once they are.
Yeah, sure. So generally, if you're seeing your provider on a regular basis, you're getting routine labs. And as part of those routine labs, we check glucose levels. If there is a concern, like you have a family member, you're concerned for yourself, you can bring it up with your provider and just ask for more specific. You could potentially ask for an A1C if you want to know more detailed information that you've been having over the past, 3 months. So if, providers requesting routine labs, they get them every year. If you're in your 20s or 30s, maybe you only get them every 2 to 3 years, but you can request routine labs, and then it'll show a glucose level. And then if that's off, then we can go and investigate further. So you don't necessarily have to start out with medication. If you're type 1 diabetic, you have to be on insulin. If you're type 2 diabetic, the first line treatment is diet and lifestyle changes. So we'll try and counsel you on dietary changes. We will send you over to Kalina. And then exercise, we could send you into the rehabilitation services to get some ideas about exercise and what's best for you. So that's kind of the first line therapy that we would like to happen. And we can try that for a while. We'd try that maybe 3 to 6 months, see how it goes, see if you can make those changes. And if the changes are effective, If they're not effective, then we might have to start out on like a low dose medication, and then we just kind of go from there. We just keep checking in every few months until we kind of get it all solidified and figured out. Did I answer both the questions?
Of course, yeah. And the last comment I guess I wanted to make was is a surprising stat that so many people don't know that they're pre-diabetic or have diabetes. And this is a conversation I have with my patients in the emergency department. Is I really try to encourage them to empower themselves with their knowledge of their own health and what their options are. And it's really hard to counsel or guide someone if they don't know the kind of challenges that they're facing. So I for those listening, I strongly encourage you or your family members to make sure you're attending your at least your annual check-ins with your primary care physician so that you can kind of be in charge of your health and know what you're up against and what your options are. But Elizabeth, thank you so much. That was awesome.
Thank you.
All right, we're going to go to Kalina Gardiner next. Kalina provides nutritional care for NIHD's inpatient and outpatient communities. She received her undergraduate degree in nutritional services from California Polytechnic University in San Luis Obispo. And she had her supervised practice obtained through the University of Nevada in Las Vegas. Kalina believes in a non-diet approach and instead opts for creating sustainable lifestyle habits. She helps guide patients in making healthier, informed decisions about their health and well-being. All right, Kalina, what do you got for us?
Okay. Can you guys see that? Okay, great. Hey everyone, my name is Kalina Gardiner. I'm the registered dietitian, clinical dietitian here at Northern Inyo Hospital. So today I'll be talking about eating with diabetes, and Elizabeth is totally right about it's hard to make dietary changes. It's behavior change. I think any behavior change is really it's really difficult, and that's why I do opt for a non-diet approach. And this is so like non-diet approach is more like let's incorporate healthy habits into your life instead of like having like a diet mindset. Usually diets are temporary, they're short term, they're really restrictive. And usually if people are really restrictive, it just doesn't work. And then you start thinking about all these foods that you've like cut out of your diet. And then at some point you end up like going and eating all those foods. And then you're just like, screw it, my diet's done. And people just get, they just get all, worked up about this. So I really try to incorporate people's food that they already eat. I like to take into consideration their preferences, their culture, what they're already eating at home. I mean, food is like so tied to our family history. Maybe there's like recipes that have been passed down from our great grandmother. And so I think that we should still honor those, and we should still enjoy all of the foods that we typically eat. But sometimes there's just some adjustments that need to be made. And of course, like everything in moderation. So these are some of the handouts that I typically use in my outpatient practice. And some of them are from the American Diabetes Association, and then other ones are from other organizations. And I really like these. It shows different cultural foods, so everything can kind of fit into a diet that's aimed for people with diabetes. So as you can see here, they're all a little bit different, but some of the things that are similar are having half of your plate being vegetables or colors, as I like to call it, just a variety of low starch veggies. And then we have the carbohydrates as a quarter of the plate. The carbohydrates or grains or starches. And then we have a quarter of the plate is going to be protein. And then of course, not everything's going to look like this. Like, how about if you make a stew, like I showed on my last slide, but it's all just about taking it apart, seeing if you were to separate all the different types of foods that are in there, how would it align to these plates? So what foods raise our blood sugars? So these are carbohydrates. And a lot of times people come in and they have diabetes and they don't know what kind of foods raise their blood sugars. So it's carbohydrates, and carbohydrates are pastas, potatoes, corn. A lot of people think corn is a vegetable, but it's actually a grain. So corn will raise our blood sugars. There's fruit, bread, beans, milk. Beans and milk are really excellent sources of protein, but they are also high in carbohydrates. And like milk, for example, it has lactose. That's the sugar that's in it, so that will raise our blood sugars. And then, of course, the candy, cakes, desserts, and soda, those are really typical ones that will just really raise our blood sugars pretty fast. So the things that are different, like say you take pasta and potatoes and bread, that doesn't necessarily have sugar in it, but what happens when we ingest that pasta and potatoes is that it turns into sugar in our bodies, so it can actually be used by our cells, and then that's where the issue comes in. Like Elizabeth was saying, that insulin doesn't work well, especially for people with type 2 diabetes. And then it just ends up hanging out around the outside of the cell and not getting into the cell. But we do need carbohydrates in our diet, just in the right amount, really trying to get at a quarter of the plate if you're doing the My Plate approach. And so fiber is a really, really big thing. This is what I'm always stressing to people. So I'll ask people what they know about fiber, and usually they say that it helps them go to the bathroom, which is totally true. It does promote regularity, and it also helps to prevent constipation. What it can also do is manage our blood glucose levels. So the more food that a fiber has, or the more fiber a food has, they won't spike that blood sugar as much. It'll be more of a steady spike in it. It can also lower blood cholesterol, which is really great because people with diabetes, a lot of times they'll have high cholesterol as well. So fiber, what is fiber? Where do you find it? It's in plant matter. So it's not going to be found in animal products. It'll be found in whole grains, in fruit, veggies, nuts, seeds, beans. So anything that grows from the ground, you're going to find fiber there. And so I've mentioned whole grains a couple times. What is a whole grain? So on the left of the screen, it says whole grain, and you can think of this as brown rice, or you can think of this as whole wheat. So all rice, like all white rice that you find on your store shelves, was once brown rice, and it goes through that milling process, and it takes away the bran and the germ. So it takes away the two layers, and then you get this really nice white rice. Same with whole wheat. It goes through that milling process, and they turn it into white flour. But when they do that milling process, you're taking away all of the fiber, essentially all of the fiber. And then also you take away a lot of other really good things like vitamins, minerals, vitamin E, healthy fats, phytochemicals, which that's been shown to prevent cancer. So you're really missing out on a lot of great nutrients when you're not choosing the whole grain. So I love this picture. I think here in the US, we're so accustomed to eating like corn, rice, and whole and wheat. But there's so many other types of grains out there that I encourage people to try. Like for instance, quinoa is a popular one. That one, it is a carbohydrate, but it's also a complete protein. So that's a really great one to have. You can pair it with some vegetables, and it's just this like really incredible, nutritious dish that's super nutrient dense. There's also, there's things like farro. There's also buckwheat, which is a really nice substitute to oats. Like a lot of people will have buckwheat in the morning for like warm cereal, and that is super tasty. And if you're used to oats, maybe you're getting a little tired of it, switch it up to buckwheat. There's also amaranth and teff, which are complete proteins as well. Those are really interesting whole grains. So yeah, there's just so many different types of grains out there, and I encourage people to give one of them a try. So how to find whole grains. the Whole Grain Council is starting to put out this stamp, and I always call it like the postage, the whole grain postage stamp, or the stamp of whole grain approval, because it looks like a postage stamp. And there's 3 different types of stamps here. The one is 100% stamp, and that means that 100% of the grain that's in the product is whole grain. And then you have the 50%, which is 50% of the grain is whole grain. And then you have the basic stamp, which it's still a really significant source of whole grains, but maybe not all of it is going to be that whole grain. Things that you can look for on the ingredient list would be whole grain, oats, oatmeal, brown rice, millet, things like that. Those are all whole grains, and that'll just be in the ingredient list. So it's really nice to just start looking at those nutrition labels to become like a really informed consumer and know what's in your product that you're buying. So here's another nutrition facts label. So typically when people come in, and they first get diagnosed with diabetes and maybe they don't really know too much, I'm always encouraging them to look at the total carbohydrates on the nutrition facts label. So it's always going to be around the middle of the label. It's in bold, and this one has 34 grams of total carbohydrates. And below that will be the fiber. It'll be listed as dietary fiber, and we want high dietary fiber because that will lower the impact on our blood sugars. We also want to look for low total sugars and low added sugars. So as you can see here, this product has 4 grams of added sugars. So that means that 4 grams of that 5 grams has been added in. Like maybe they added in with like pure cane sugar, or maybe it was high fructose corn syrup, something like that. But so we want to have low added sugar and low total sugar too. So in this product, since there's 4 grams added sugar, then that means that 1 gram is naturally occurring. So maybe there was like a little bit of fruit in there, or maybe there was some milk in there that gave that 1 gram of naturally occurring sugars. So if you're carbohydrate counting, which I encourage people with diabetes to become familiar with, each meal can have around 30 to 45 grams of carbs per meal, and then each snack can have around 15 to 30 grams of carbohydrates. Okay, so I think that we talk a lot about carbohydrates with people with diabetes, but it's also really important, I think, to focus on protein and the other food sources too. So protein is really important. Just eating protein can improve our blood sugar levels. It can promote satiety or a feeling of fullness, and it also preserves lean body mass, which is super important, especially the older we get. We really need to preserve that lean body mass. Something that you can do, like just the preparation for it to be a little bit healthier, is try baking it or roasting it, poaching, grilling, instead of frying and using a bunch of added oils. So some of the proteins, like the best proteins, are listed here on the slide. The number 1 probably recommended one that I do for diabetes is fish. It's super high in omega-3s, and omega-3s can reduce your inflammation, and it also has been shown to increase our insulin sensitivity, which is what we want. We want to be insulin sensitive so that insulin works to take in that glucose. So if someone hates fish, if you do want to supplement, that is one supplement that I would recommend if you don't get fish in your diet and you're interested in it, is a high quality fish supplement. Lentils is really great. It's super high in fiber, high in protein. It is a carbohydrate, so you have to be mindful of that, but just the fiber and the protein content is really great for us. Tofu, it's made from soybeans, super low in carbs, really high in protein, and like really great on the wallet. Also, if you don't like tofu, you can try edamame or tempeh. Also nuts, they're really high in healthy fats. So that means unsaturated fats, and that just improves inflammation and blood pressure. Diabetes is considered a inflammatory disease, so that's why I've been mentioning a lot of the inflammation here. Also, eggs and chicken are really great. Sometimes how I like to think of protein is like in terms of legs. So you have beef and pork they have 4 legs, and then they are really high in saturated fat. And then you have the poultry, the chicken and the turkey, they have 2 legs, they're not as high in saturated fat. And then the fish, beans, tofu, nuts, seeds, they have 0 legs, they're really healthy for us. So that's just a fun way to kind of remember the different types of protein. So reducing our saturated fat intake, really important too. There's research out there that is showing that when someone has a really high intake of saturated fat, that can actually cause a greater degree of insulin resistance with people living with diabetes and without diabetes. So this is important for everyone, trying to reduce our saturated fat intake, because that can lead to insulin resistance. Insulin resistance is a big cause of type 2 diabetes. What is saturated fat? It's that solid fat, and it's usually comes from animal fats. So red meat, bacon, butter, lard, cream sauces, poultry skin, things like that. Okay, and then how to look for saturated fat on your food labels. I have it highlighted. The total fat is highlighted in yellow, and then the saturated fat is below that. It's highlighted in yellow as well. So we want to choose foods with less than 2 grams per serving of saturated fat, and trying to choose 0 grams of saturated fat. All food labels, they have to put the saturated fat on there, and they have to put the trans fat on there because those are the worst types of fat for us. So instead of choosing butter and lard and things like that to cook with, choosing oils, because that's the unsaturated fat. So really great options to include are flaxseed, canola oil, avocado oil, sesame oil, and olive oil. Those are the ones that really have a lot of omega-3s in them, which help with our anti-inflammation. I have to note the gut bacteria and the gut microbiome. This is just like such a fascinating field. There's so much research going on about this right now, and they've been linking it to diabetes. So our gut microbiome, I like to think of it as this like internal metropolis of billions of bacteria that are living mainly in our gut, in our large and small intestines. And it's actually been labeled as a supporting organ in our body. So that's pretty significant. So the more good food that we feed our microbiome, we can possibly help prevent chronic diseases like diabetes, because literally our gut microbiome is feeding off the food that we feed it. So what should we feed it? We should feed it a lot of fiber. So plants, beans, veggies, fruit, things like that. And also what we can do is eat probiotics. So probiotics doesn't have to come from a pill. It can also come from like yogurt or kefir, kimchi, sauerkraut. And what you want to do is look for those live active cultures that are on the food label. And this is a food label. This is one of the yogurts. This is, I think, a really great yogurt. And as you can see, the ingredients, there's only 2 ingredients, which is pretty amazing. It's milk and live active cultures. And it'll always say live active cultures if it is actually has probiotics in it, and it will list the live active cultures right there on it. And so just, I guess, maybe a plug for this yogurt. You can look at the total sugars. It has 5 grams that's naturally occurring, and then you look underneath it, it says 0 grams added sugars. So this one's a really great one, and it's high in protein, 19 grams of protein. So this is a really good one. So the main takeaways on this, really eat more veggies. I would say I'm a self-proclaimed veggie pusher. Typically, most people need to eat more vegetables. Also whole grains like brown rice, whole wheat pasta, quinoa, farro, things like that. Instead of choosing the white rice and the white bread, making those simple choices to do whole grains. Also eating we want to eat carbohydrates, but we also want to limit our intake to 1/4 of the plate. Trying to include a probiotic into your everyday diet. Maybe if you don't just like straight up yogurt, maybe you put it into a smoothie, or you put like a dollop of yogurt onto your breakfast cereals in the morning. We also want to reduce saturated fats and opt for unsaturated fats like the olive oil and canola oil. We want to reduce the added sugars in our diet. And we also want to pick a good protein source. Enjoying our food is really important. So hopefully we can find a way to enjoy our food through even some of the dietary changes. It's probably one of the most satisfying things is whenever someone comes in and they're like, whoa, I've been having fun exploring new foods, or I'm just learning a lot more about myself from changing my diet a little bit. Also, another great thing to do is make an appointment with your local dietitian or diabetes educator to learn more about this. Most insurances, once you get diagnosed with diabetes or pre-diabetes, you have up to 3 sessions per year with the dietitian that will typically be covered by your insurance. So that's just a plug for me and all the other diabetes educators and dietitians out there. And then, of course, I always talk about the importance of exercise, but since Joanne's here, she's gonna do a way better job than I could.
Awesome. Well, thank you so much, Kalina. I know I personally struggle with the portion thing, and the knowing what is a portion and the quarter of a plate, I think, is a great way of calculating that. I'll just do my best not to pile my rice too high and cheat on the quarter of the plate method. Kalina, if someone went and saw Elizabeth and they found out that they have pre-diabetes or recently diagnosed with diabetes, and they'd like to see you and they forgot to ask their primary provider, or maybe they just had their appointment and they don't see their provider for a few months, what's the best way to get on your schedule and to make an appointment to see you?
So I always tell people if they're here at Northern Annual Hospital, they can email or they can message their provider through the portal. So definitely get on that patient portal, message them. And typically, if they do have diabetes or pre-diabetes or even obesity, the provider will write an order to come see me or a recommendation to come see the dietitian. And then also, typically, if you guys call me directly, we can talk, see if it's a good fit, and I can also call the provider too. It's great. That's typically a good way to do it.
And then the last question I'll ask you is, I think some patients and people might be worried to go see a dietitian because they don't want to be told that they can't eat their favorite foods, ice creams or brownies or those types of things. Is there a role for those foods, and how do you approach allowing patients to kind of still have a place for those types of foods that bring them joy or happiness, or maybe they have some emotional attachment to culturally?
Yeah, absolutely. No, I think that's a great question. I think a lot of patients, they're scared to come in here because they think that I'm just gonna totally bash their diet or something. I think that all foods should be enjoyed. I think in moderation is huge. A lot of times, what I'll say, like, okay, you really want your cookie at night, or maybe you really want your chips or something. Okay, have your chips, but then also throw in 3 baby carrots. And then, so you're having your chips, you're having your fun food, and then you're also having a food that really supports your health. Same with like your cookie or something. Okay, you want your cookie? How about if you do, like, instead of having 3 cookies, do 1 cookie and have some fruit with it, and maybe a little bit of yogurt to, like, low sugar yogurt. So I try to really just add things in. I'm not a big person about taking things out of your diet, but adding them in. How can we add healthier foods in to help to really support your health?
Awesome. Well, thanks so much, Kalina. That was a great talk.
Thanks.
All right. And our last panelist tonight is going to be Joanne Henze. So Joanne graduated with honors from the University of Miami and Emory University. She's a board certified clinical specialist in both geriatric physical therapy and pediatric physical therapy. She has extensive experience working with children and adults of all ages and abilities, and strives to help her patients reach their physical rehabilitation goals and to maximize their quality of life. Joanne currently serves as our Director of Rehab Services. And Joanne, go ahead and take it away.
Thank you, Dr. Hawkins. Let's see if I can show the screen. Can you guys see the screen? Okay. So I'm going to be talking about exercise and diabetes. And Elizabeth and Kalina both touched on how exercise affects diabetes. And basically, it's been well established that physical activity helps to control blood sugar levels. And it's because exercise increases our body's sensitivity to insulin, which allows our body to use blood glucose for energy. Additional benefits of exercise include promoting healthy weight, improving mood, helps to control blood pressure, improves sleep, improves cholesterol levels, improves memory, and also lowers risk of heart disease. Now, how much physical activity do I need? So the current recommendation is at least 150 minutes per week of moderate intensity physical activity. And that works out to be about 20 to 25 minutes per day minimum. And moderate activity, a good way to kind of understand that would be where you feel like you're working, you're breathing hard, you can still have a conversation, but you maybe don't really want to. So you want to be working hard enough that your breathing is a little bit harder, but not to the point where you feel like you can't talk at all. And ideally, you want to try to include both aerobic and strengthening activities. Some examples of physical activities, really anything where you're moving your body, but walking, it can be housework, gardening, or yard work, dancing, swimming, bicycle, playing sports, really anything, like I said, where you're moving your body. It doesn't necessarily have to be the traditional ideas of exercise that people think about, going to the gym and so forth. Getting started, if you're not already physically active, it's really important that you check with your doctor before starting any exercise program. Make sure if you have any other health conditions or medical issues that your doctor needs to be aware of, or that you're on the same page in terms of how that could affect your ability to exercise. Then after that, you want to start with an activity that you enjoy. As Kalina said, you know, food should be enjoyed, but activities should also be enjoyed. If it's something you don't enjoy, you're not going to really stick with it. So there's a lot of different options out there that, you know, you just really have to choose what's right for you, what's going to fit in with your lifestyle and things that you enjoy. Starting small is perfectly fine, and gradually adding more. Again, if you're not already physically active, you know, you can start with just 5 minutes a day. You know, the goal is 20 to 25 minutes a day, but if you can only do 5, you know, 5 minutes, 3 to 4 days a week, that's a start. And then you gradually add in more frequency and longer duration of activity as you can tolerate it. A good way to get started is also just incorporating physical activity into your daily routines. You know, just parking a little bit farther away from the store or from your work and walking a little bit farther, taking the stairs, those types of things. Finding a partner to help hold you accountable. So exercising with a friend or a family member can kind of help keep you on track. And like I said, keep you accountable for if you are supposed to be doing a scheduled activity, that you kind of show up for that other person and vice versa. And also just making it something that you schedule into your daily life. So planning, you know, carving out time in the morning, or maybe going for a walk after lunch, or some sort of set time where, if, you know, if we schedule it in, then we're more likely to follow through with that. And then just setting realistic goals. Again, you know, if you're not already physically active, you don't want to set yourself up for failure and say, okay, I'm going to go to the gym 7 days a week for 2 hours, because that's just not realistic. So, you know, starting out small with, you know, whatever you feel like you can realistically achieve in, you know, in a month or so, and then, you know, gradually update those goals as you make progress. Some special considerations with diabetes. It's really important to check your blood sugar before starting any physical activity. You don't want to be too low, because when you exercise, it will lower your blood sugar. And you also don't want to be too high. So again, you'd consult with your doctor for specific recommendations and parameters as far as limitations on that. Proper footwear is another really important factor with diabetes. You want to make sure you're wearing comfortable socks and shoes to avoid any kind of skin irritation or blisters. And then obviously you want to check your feet for sores or other injuries after you do an activity. Of course, drinking plenty of fluids to prevent dehydration. And then you can also check your blood sugar after doing an exercise or doing an activity to see the changes. So that's one way to kind of help reinforce the benefits of exercise, because I think people can actually see that, you know, before I started, it was at whatever amount, and then you'll see that change even with just a little bit of activity. So sometimes that can help with, you know, kind of a tangible result that this is actually helping before you're seeing some of the long-term changes. And that's all I have about that. I wanted to share also that our rehab department can help support people if they're trying to get started with an exercise program. Our physical therapists are experts in exercise and movement and can help with establishing an exercise program, but also if someone is having other physical challenges that may limit their ability to exercise. So say I just got diagnosed with diabetes and I want to go for a walk, but I have knee pain or back pain or hip pain. So that may be something you could talk to your doctor about, referring to physical therapy to help address those other issues that may be hindering being able to exercise. And that's all I have.
Great. Thanks so much, Joanne. Joanne, there are a few questions in the audience I was going to ask mine. One of our audience members asked, if a child has special needs and diabetes, how important is it for the child to exercise regularly, or is diet more important in the group's opinion? Specifically, I think referring to a child who might have autism.
I don't know about more important. I think it's definitely important. I think children in general need, well, depending on the age of the child, to the younger children, the guidelines are just they need to be moving and active throughout the day. As we get older, we kind of have the, as an adult, we're looking towards more like carving out 20 minutes if we can to go for a walk and do a specific activity. But, children in general should be moving. They should be playing at recess, moving around. And what was the question again? What was, how important is exercise?
It also asked, or is diet more important in the group's opinion, or how important is exercising regularly with a child in terms of a child who's suffering from both diabetes and autism?
Yeah, I mean, I think it's just a component of it. Like there's three of us talking on all three levels. So I don't think I wouldn't emphasize one over the other. I think all three, avenues need to be addressed. Now for a child, when you think about a child in exercise, I wouldn't view it as a like getting into a formal exercise program, more as physical activity. So just getting outside more and playing, going to the park, going for a walk, walking the dog, things like that, versus sitting a child down and expecting them to do, 10 minutes on a bicycle or something like that, unless they go out, unless they enjoy like riding their bike or something. Normal play-based activities that are just physically active where they're moving their body are more beneficial, more realistic, versus trying to get a child to, do a regimented kind of exercise program. Does that make sense? I hope I'm answering the question.
Absolutely. And then there's one other question. Is there value to wearing compression socks during exercise?
In terms of diabetes specifically, or?
I think potentially in terms of diabetes, but also just maybe in general for all patients.
I think that would be an individualized answer, and that would be something I'd defer to the your provider or your doctor. Compression socks and things can help with circulation, but if you have some sort of cardiac issue, you don't want to overload the heart as well. And then with diabetes, you worry about skin integrity and things, so you don't want things too tight necessarily, so that could impact perfusion to the feet.
Great. One of the things. Oh, go ahead.
Well, I just wanted to add to that exercise is kind of like wearing compression socks already, in that the use of the muscles is actually pushing the fluid back into the body. So hopefully if they're exercising regularly, they won't actually need to use compression socks unless they're on their feet all day, without doing any activity. If you know what I mean.
Joanne, one of the comments you made, I think, really resonated with me. When I was younger, I associated exercise with kind of a traditional, like working out in a gym. And, especially this time of year when it's dark outside, I think you would set yourself up. You'd set these unrealistic expectations for yourself where, your work day ends and it's 5:30 and you're just too tired to go work out for 2 hours in the gym, or maybe you have a family or other obligations. And then really reframing in my mind what exercise is. And even if you're just able to go on a walk or incorporating movement into your day, that way it's something that's attainable. And it's also just a habit that you start to build. And the studies have started to show the tremendous health benefits of just walking. I think a lot of our day, a lot of our world is set around a desk and a chair and being sedentary. So finding some way, just standing up, walking, to Elizabeth's point, it promotes circulation. It promotes circulation of our blood and our lymphatics. But for our patients with diabetes, you definitely have to be cognizant of the footwear, because you don't want to walk barefoot around on hard ground and get a wound and create more problems for yourself. We had another question come in. I was wondering why. The question is, I was wondering why I feel like I have to eat a meat dish for dinner because vegetarian meals just don't keep me full long enough. I love vegetarian meals, but feel even if I eat a large portion for dinner, I feel hungry within 2 hours. I work labor and I require a lot of calories to sustain myself for the work I do, and I'm conflicted on why I feel the way if vegetarian meals are much more nutrient dense. Should I be eating more carbohydrates to keep me full for a longer time? That's a good question.
Yeah, so that is a really good question. I think that most people who choose to eat vegetarian meals, or they're all of a sudden like, hey, I'm gonna have this vegetarian meal. Maybe they're not getting enough fat in with that meal, because meat typically does have more fat. So maybe adding like a little bit more olive oil to your veggies, like after you cook them, adding some more veggies, making sure that you have enough beans in there. And then, yeah, having enough like complex carbohydrates like that brown rice or quinoa or something like that. So making sure that you have enough protein and you have enough fat in your dish. I think those two components can be really important to making someone feel full after their meal. So a lot of times, yeah, the calories just don't equal up. So you'll just have to eat more, or maybe you're full because it has so much fiber, and then you'll get full after, a normal meal, and you might have to come back in a couple of hours for a snack or something like that. But that's okay, so it's kind of just balancing those calories out.
All right, last call for any questions from the audience members. I just want to say that I feel super grateful to have providers like Kalina and Joanne and Elizabeth here. We have so many different ways to cater to our patients' health outside of just traditional medications. Diabetes in particular can be incredibly confusing. It can be daunting. It can be frustrating, and patients, I think, can just throw the baby out with the bathwater and kind of throw their hands up. So I really encourage you again to empower yourself with knowledge. Go see your provider and at least get your journey started. It looks like we had one other question come in. My children do not enjoy healthy food. How do I get them to start eating healthier?
Yeah, that's a really good one. I get so many picky eaters in my office. So, and sometimes that's just how it is. Like, children are just picky in general, but taste buds change over time. And sometimes just like kids, they're also like becoming like autonomous. They're making choices for themselves. So that's one way that they can really control their food and have any control is through their food intake. So I think something that's really important is offering the food multiple times, being a good role model. Like, the parents are eating well, then more than likely the kids are going to start to eat just like the parents are. And then also too, if like your kids are really into like snacking and they're like, no, I'm not hungry during dinner, but then like right after dinner, they're like, I want a snack. Sometimes you can just be like, yeah, the kitchen's closed, or just having some kind of technique where you're like, the kitchen's closed. The kids will start to learn like, oh, the kitchen's closed. Okay, I can only eat when the kitchen's open. So I better eat during dinner time. But I think like reintroducing foods multiple times, research has shown like up to 20 times you need to show a kid a type of food for them to start enjoying it.
All right.
And if I could just add on a medical, from the medical side, that when children, like she said, that like Kalina said, the taste buds, by the time we reach our 20s, we've lost, I don't remember the exact percentage, but it's a huge percentage of our taste buds. And so when children, taste a food and they like, or, makes them gag, or they're like, oh, that's gross. They have a lot more taste buds than we do. So these flavors are really strong for them. And so, we just have to kind of take that into account. And as they get older, they may actually, as they lose their taste buds, they might actually be more open to different flavors as well.
Yeah, that's absolutely true. So it is true whenever you get older, you do lose those taste buds. Then you can start eating more bitter foods too when you get older. That's totally true because the taste buds are not there.
Great. Well, thank you all for your time. Thank you, audience members, for joining us tonight. Hopefully everyone's hungry after Kalina's talk and goes enjoys a healthy dinner. Barbara, thank you so much for setting this up, and we'll see you all next month for an NIHD Healthy Lifestyle Talk.
Thanks, guys.
Thank you.
Bye.